Hello, I'm hematologist-oncologist Dr. Tony Talebi, and we're back with Dr. Dr Salsamendi, Assistant Professor of Radiology at University of Miami, and now we're going to discuss chemoembolization. Dr. Salsamendi, what is chemoembolization?
Chemoembolization is an excellent technique, mainly for treating liver tumors or metastasis to the liver, where we take advantage of the embolic effect of administering microparticles to the artery, which primarily supplies these lesions, and also it takes advantage of the direct administration of chemotherapy to the liver lesion, and that synergistic effect yields usually very good results in terms of controlling liver metastasis or primary liver lesions in the tumor.
What typical cancers would this procedure be used for?
It's frequently used at our institution and elsewhere for treatment of hepatocellular carcinoma. It's also used for treating colorectal metastases, neuroendocrine tumors, and primary malignancies of the biliary system, cholangiocarcinomas, or gallbladder metastasis to the liver.
And what should the patient do the night before or the morning of the procedure?
That's a very good question, and it does vary a little bit from institutions. In our institution, if they have hepatocellular carcinoma, we're going to be treating with our regimen of doxorubicin on drug-eluted beads. They come in the day of the procedure, they refrain from eating overnight, and they also are contacted by our nurses and physicians to ensure that the medications that they're taking are not going to interfere with the treatment. And the day of the procedure, they're hydrated, they're given medications to prevent nausea and vomiting, and then we proceed with the angiogram and embolization all in one treatment, one session. And they can always follow up for repeat sessions if needed. And our patients do stay overnight. They may not need to, but we prefer to have them stay overnight to make sure that they have adequate pain control, that they can tolerate eating, and also feel strong enough to go home the next day. And most patients go home early the following day.
What if the patient has allergies to shellfish or claustrophobia? Does that change how this is done in any way?
Well, we address allergies. There is a conception that allergy to shellfish translates to allergy to contrast, and that really hasn't been proven out. But if they do have a great previous history of allergy to prior contrast administration, we determine what kind of reaction it is and pre-medicate them as necessary. If they have other allergies, then we have to see if we can pre-medicate for those as well, or avoid those medications during the procedure. And the second question was,
what if they're claustrophobic?
If they're claustrophobic, well, fortunately in the angio suite, there's a sense of openness. It's just a flat panel that's overlying their abdomen. There should be nothing covering the head area. So we don't have the typical scenario of claustrophobia as we do with other imaging modalities like MRI or CT.
I see. But what if they're actively receiving intravenous chemotherapy? How does that really play into the chemoembolization?
Again, it's a good discussion for that. If they're if they're on a chemotherapy regimen, we need to discuss with the oncologists and look at their liver function tests, make sure they can tolerate combined treatment. In a lot of cases, we have to give them a little bit of holiday and restart afterwards. However, again, with hepatocellular carcinoma with Nexavar, sometimes we do concomitant treatment. So it really is at the discretion of the oncologist and interventional radiologist. It depends on the institution.
What should the patient experience during the procedure and after the procedure?
During the procedure, they're going to receive conscious sedation. They'll be awake, but they will be in a state of twilight, so that they'll be a little disconnected and not as concerned about the procedure. However, they're awake and able to follow instructions. We give lidocaine to the groin area so that they're numb. They may feel some pressure in that area, but they should not feel any pain. During the procedure, it depends if we're giving irinotecan or doxorubicin. Doxorubicin is for hepatocellular carcinoma, and irinotecan we usually give for metastatic colorectal. Irinotecan is a little bit more difficult to tolerate, so those patients are actually admitted the day before, and they're given aggressive narcotic treatment or other pain medicines during the therapy, so that it prevents them from having pain or limits the pain during the treatment. Doxorubicin, again, they're admitted the day of the procedure, not the day before, and they usually tolerate the chemoembolization a lot better with less pain medicine requirement, less narcotics needed during the treatment.
I see. Now, we were discussing radioembolization previous video. In terms of for colon cancer patients, when do you prefer this procedure versus the yttrium 90?
There's a little bit of overlap in terms of which patients are best suited for each of those procedures. One area that is of interest is those patients that have portal vein thrombosis, and typically they are not good candidates for chemoembolization because when there's no portal venous supply to the liver, and then after embolization there's arterial supply, then that area of the liver is effectively infarcted, and we want to avoid that because that can lead to abscess formation, myelomas, and other complications down the road. So in those patients, the radioembolization spheres are much smaller, and they have a tendency to, although treat the tumor, have less embolic effect. So even in the setting of portal vein thrombosis, we can administer those beads with less complications.
That's very interesting.
So that would be one area where there's a significant advantage to one treatment over the other. And then the other intricacies of the procedure, I think, are more institutional, depending on how frequent that procedure is performed by certain operators, and there's subtleties in that.
I see, that's very interesting. So back to chemoembolization, what should prompt a patient to either call you or go to the emergency room after the procedure's been done?
Okay, so in terms of post-procedure care, patients do have some nausea, may have some vomiting the first 24 hours. That's just starting to subside with every day. At 4 weeks, they should be back to their usual baseline, usual functional status. However, during that time period, if they have spiking fevers, not just 101, but 102, 103, spiking fevers and chills and worsening abdominal pain, that could all be signs of a complication, or it just could be a little bit of a rocky recovery. But in any scenario, they should contact their physician, oncologist, interventional radiologist, or if necessary, go to the ER just to be evaluated.
I see. And are there any limitations to this procedure?
Chemoembolization is limited from one aspect of the liver gets this blood supply, unlike other organs. It has dual blood supply from the hepatic artery and the portal vein. So chemoembolization takes advantage of that by blocking the hepatic artery and still being able to perfuse the normal liver tissue to the portal vein. So one of the main limitations is that when the portal vein is thrombosed, we really can't offer this treatment because we're going to effectively take away all the blood supply to the liver. That's the one limitation. And the second major one is those patients with limited liver function, and we look at their liver function tests, including bilirubin and albumin. If their bilirubin is a 2 to 3 range, and definitely above 3, they're most likely going to have significant side effects of the treatment. So we have to be very careful with those patients.
Well, thank you so much.
Okay.
Thank you for watching. We hope this has been educational for you as well.